So it's 8 o'clock and welcome to today's episode of Marvelous Medicine, which is all you need to know about breast cancer. The speaker is Dr.Selvi Radhakrishna. She's a consultant oncoplastic surgeon at Chennai Beast Centre, which is a state-of-the-art breast cancer center she herself set up. Dr. Selvi did her MBBS in 1988 from Madras Medical College. She's a diplomat of National Board in General Surgery and also a fellow of the Royal College of Surgeons of Edinburgh. Dr. Selvi went on to do a postgraduate diploma in clinical oncology at the University of Birmingham. She has made several national and international presentations and has several publications on breast cancer to her credit, and has also authored a book chapter. She's written a book called titled Breast Diseases, Imaging and Clinical Management, and another one called All About Breast Cancer for Patients, which is both in Tamil and English. Her current area of interest is preventing breast cancer and many other lifestyle disorders with lifestyle modification, including intermittent fasting and exercise. Her other interests include learning Sanskrit, Vedic astrology, and Advaita Vedanta. Thank you, Dr. Selvi Radhakrishna, for agreeing to do this session when I know it's perhaps going to be well past your bedtime. Moderating the session will be Dr. Geeta Kadeyaprath. I hope I pronounced it right. She's a senior consultant and lead of breast surgical oncology and oncoplastic surgery at Apollo Women Cancer Center at Delhi. Dr. Geeta did her MBBS from Lady Hardinge Medical College, her MS surgery from Maulana Azad. She's also a fellow of the Royal College of Surgeons of Glasgow, and she did a fellowship in the breast unit of the Royal Marsden Hospital. Dr. Geeta has over 50 publications to her credit. She's the Vice President of Oncology Forum Delhi and the Founder President of Comprehensive Breast Collaborative Society. And Economic Times awarded her the Inspiring Woman Leader Award in 2022. And she's also the co-founder of Bliss Foundation, which is an NGO which works to create cancer awareness. Thank you, Dr. Geeta, for accepting our invitation at very, very short notice. Over to you, Selvi.
Thank you. So
you got to hit play, I guess.
Yeah. So are we seeing the screen?
Yes.
So breast cancer is the most common cancer affecting women in India. And if you see, this is the stats from International Agency for Research on Cancer, IARC stats. Close to 14 million new cases, cancer cases in the country. And the death rates are about 9 million. And if you see the list, I'll show the next one. It's in women, breast tops the list. And if you put men and women put together, breast again tops the list in terms of incidence as well as mortality. So, and I've just highlighted the 3 states in the south, I mean 2 states and 1 union territory in the south. And if you see from 2019 to 23, this is the Globocan hospital-based tumor registry statistics, and you can see there is a it's not static, it's consistently definitely increasing and the trend of rising incidence of breast cancer is likely to continue, and this is majorly because of change in lifestyle factors, basically reproductive behavior and dietary habits. And so we all, whenever I describe estrogen dependency or hormone dependent breast cancer to patients, I always give this example. There is a plant that is growing, and then that plant needs sunlight, it needs water, it needs fertilizer, and for it to grow. And estrogen, we always thought that it is a catalyst for the tumor to grow. But now there was a very very complex to understand study done presented in Nature by Jake Lee. And so he also talks about copy number amplification occurring in sections of genes, just like HER2 amplification. And this is driven by estrogen. So it is not only a catalyst, but it also could be a cause. And so this explains a lot of postmenopausal breast cancer, particularly that is associated, postmenopausal ER positive breast cancer is associated with obesity. We all know, fat. Again, there's more estrogen because peripheral conversion of androstenedione to estradiol, and that happens, and it becomes a significant risk factor. So if you look at all the risk factors combined, the reproductive risk factors are the ones that we talk about: early menarche, less children, not breastfeeding, late menopause. So all this is centered around estrogen, the increased number of menstrual cycles. If you see from early menarche to late menopause, childbirth, having many children actually was protective because 10 months of not having cycles, and breastfeeding, again, when a woman breastfeeds, she does not have cycles for a few months before the cycles reestablish. So all this was protective. And so the most understood risk factors are the reproductive risk factors, and then the hereditary breast ovarian cancer syndrome. That component contributes to about 5 to 10% of breast cancer. And then what we understand, obesity and other things like alcohol, all our lifestyle associated breast cancer. So this is the much we know now. And so early detection offers the most effective treatment options with long-term survival and quality of life. And in our country, mortality is high, and this is attributed to late stage at presentation. So up until now, at least in all the major regional cancer centers, and public sector hospitals, locally advanced breast cancer contributes to about 60 to 70% of all breast cancers in this country. Whereas in the urban, more affluent cancer centers and private cancer centers, we see more stage 2 and stage 1 breast cancers. There's also a lot of disparities in cancer care. So this also affects outcomes. And so this is, on the one extreme we have this, and on the other extreme we have our own issues in dealing with detection and treatment related issues. So the major challenge that we see is women themselves. There's a lot of lack of awareness, painful, so this is not cancer; painless, so this is not cancer. So I thought this was something related to some breastfeeding that happened years and years ago. And also, what often foxes me is this: breast is a surface organ, unlike something that is hidden in the abdomen or the chest, inside the thorax or something like. It's not like a pancreas or a liver. It's a surface organ. You touch, you bathe, you do, every day. And I don't know why people sit with lumps that are apple-sized and orange-sized in the breast, and it's really, really depressing every time you see a lump of that size when you see a patient. And a lot of people have fear and hesitation to see doctors, fear of the treatment process, fear of the testing process. So there's so many hurdles that one has to overcome before they come to see a doctor. And then women always have this sentiment, putting family first. It's always this: my son's exam, my daughter's delivery, and all sorts of reasons, wedding, parents not well, so many reasons, husband not well. They don't give priority to their own symptoms or health. And many reasons why women come late with breast cancer. So the other major challenge is the provider related challenge. Now, Now, there's a lot of lack of awareness amongst doctors themselves. Now, we know, like, we are groping in the dark, like, blind men, like looking at the elephant and giving their own interpretation. We have different interpretations and guidelines, and I mean, no standard guidelines, and it's very difficult to enforce anything in our sort of a setup. And then coming to this larger concept, the breast cancer screening debate, it is a white elephant, at least as far as our country is concerned. The debate continues. There is, there is one group who will convincingly argue that there is no mortality benefit, and another which will say there is definitely mortality benefit, and hence we should continue to screen. So we have the Swiss Medical Board in 2014 recommended that Switzerland stop introducing new mammography screening programs and phase out existing programs. It's 10 years now. So there is still, it is still a choice. Women can undergo mammogram if they want to, but as a state recommendation, they have stopped doing state-funded mammographic screening for Swiss women. And so, it's 10 years now, and in due course, if we look at incidence, prevalence, and mortality, then it could throw some light onto whether mammography has any real mortality benefit. The Canadian breast cancer screening trial. So all this started along with the health insurance plan study in the US, and Canada started almost simultaneously with this Canadian breast cancer screening trial. There are a lot of issues with this trial. The update was published recently, a few years back, maybe about 3-4 years back, which actually gave a contradictory view, and they said screening could be counterproductive and increase mortality. So that was a bit of a shocker. But the study was flawed in many ways, because before they recruited patient into screening versus no screening arm, they were clinically examined. So there could be a bias in allocating the in the randomization process. And the technology in the 70s were not great, and there was and people who went back and looked at the mammograms done during the study period were not really happy with the quality, and there were a lot of issues with that trial. But and there are equal number of studies which say there are benefits, and people argue about whether screening, the benefit is from the age of 50 onwards or 40 to 50. And now the recommendation is 40 to 50 also should be screened. And the preventative task force in the US a few years back, came up with this two-yearly mammogram from age 40 onwards. But the American College of Radiology, the Cancer Society, the breast group, they actually want it every year. So this is all very confusing, no clear guidelines there, and you could be right with one thing, you could also be wrong with the other thing. So it's so if there's a lot of confusion there, the last word is not there yet. On the whole, the biggest confounding factors has been possibly the lead time bias, that you pick up these lesions earlier, but actually the mortality hasn't changed. And also a lot of the mortality benefit that you see could be due to the advances that happened in the management of breast cancer, and not really screening per se. So all of these could be argued out. And there is a real problem with screening as well. So we have this issue of missed cancers, interval cancers, so overdiagnosis. So we end up picking up all the innocent low-grade DCIS and probably overtreat them. With the low-grade DCIS may never ever progress to invasive carcinoma. So those are some issues. And interval cancer, so a bit with the screening interval, if it is so the European countries followed, so UK follows a 3-year interval period. And the rest of the Europe possibly follows about 2-year interval period. In the US, it's divided. It's 1 year versus 2 years. In interval cancers, which happen between two screening episodes, are the ones that are likely to be more aggressive and life-threatening. And these are the cancers that are going to be missed by mammogram. And so what is the purpose of doing mammogram? So these are some of the issues that come up in a mammographic screening debate. And also false positives. So for every screen, every 1,000 women that you screen, so for every 100 women that you screen, you get about 20 of them, you get false positives. So a false alarm, and then that leads to a lot more tests and a lot of anxiety and more procedures, and then endless follow-ups and all that. And this causes a lot of concern and healthcare costs too. So this is also another point when people talk about when debate about mammographic screening. So in general, a public screening policy should define the screening test, the screening interval, and who's eligible and who funds it. So all of these things, and there is a clear pathway. The machine that we use, the quality assurance, quality control. So in the US, they have this MQSA Act, Mammography Quality Standards Act. So we don't have such a thing in India. It's also important as far as the technology is concerned. You might have a fantastic 3D, HD, tomo machines and all that, but if your technologist is not good in doing that mammogram and positioning the breast and getting the right views, then that is a problem. So we don't have an audit of all these things happening. And then it comes to reading as well. So what your mind does not know, the eyes don't see. So the training of radiologists is very important. Now, unfortunately, our curriculum includes a lot of ultrasound, lot of CT and MR. Mammography is a very, very small part of training, because most of the teaching happens in government hospitals. Government hospitals do not have, many institutes do not have mammographic equipment. And therefore there is a disadvantage in training there. So, and there is no audit of missed cancers, recall rates, interval cancers, and all these things that are happening in the screening pathway in our country. And unless all this is there, then we shouldn't talk about population-based screening at all. And then image archival, again, it should be available for comparison. We should have some data management, audit of whatever that has been done. And then when you find a problem, we should have facilities to take it up further. So you find something, but I'm unable to do a stereotactic biopsy, or I can't do a guided biopsy, I can't localize it. Because I can't localize it, I don't know how to remove it, and then all the cascading things that follow through. And then on audit of outcomes, did the screening really matter? So all this, so there is a very delicate balance in this pathway. So now what happens in our country right now? Obviously, we don't have have a population-based screening program. In fact, we should not have. What we have is an unorganized master health checkup sector. So what we call as MHC. So every corporate hospital will have an MHC department where women are encouraged, or all people generally encouraged, to go on for all the battery of blood tests. And women, many of the packages, there are some without, but some offer mammogram. And come October and March every year, with March being associated with International Women's Day, and October being breast cancer month, a lot of discounts are offered and mammograms are done left, right, center. And so it's like a low-hanging fruit, you do this, but there's a lot of issues. We'll discuss that later when I show you some images. And then it's also driven by NGOs. So every time, most NGOs do, even I was involved in one such a program where we put in mobile machines in a mobile van and take it up from place to place, the screening vans, and institutions like the Rotary groups go and they mobilize funds to put up mammogram machines in underprivileged locations, in charitable hospitals, in government centers. So they drive the campaign for mammography. So there are pros and cons about this. So the problem is availability of technology, the technology itself. We still, lot of centers still use discarded or repurposed, refurbished machines, which are not bad, but again, there are there is better technology available and technique. So look at this image that I've projected here on the screen. Between the CC, first of all, breast is a paired organ. If you take a view, the view has to be matched. The right side should be matched the similar view with the same side. So here it says right CC here and right ML. ML is mediolateral. So this is not mediolateral. It is dead lateral. So between the CC and ML, you don't see the pec muscle at all. So it's inadequate mammogram, poor contrast, possibly poor compression, and the breast is not even included in the frame completely. It is labeled poorly. I mean, there is a standard way of labeling, which actually is very useful when you look at the quadrant. Localized inner or outer quadrant is very important to have standard labeling. So all of this is missing, and this is mammogram done fairly recently. So this is still the kind of standards sometimes that we see in our country. This happens in a metro like Chennai, and there is a lack of uniform language in the way it is reported, and BIRADS often adds to confusion. And so BIRADS was formed, breast imaging reporting data systems was a method like TIRADS, BIRADS. All this was to standardize the language used to report findings on imaging. Say, for example, in breast, it's breast imaging. So breast on mammogram, on ultrasound, on MRI. So there is a standard way of describing some findings, and by which, like when you give a score, then the clinician knows automatically whether to follow up or whether to ask for a biopsy, and the whole system is driven by the radiologist, where unfortunately here in our country there is a confusion in understanding screening and diagnostic mammograms. So the screening mammogram is obviously done in a woman who has no symptoms, whereas diagnostic mammogram is somebody who comes with pain or lump or discharge or some issue that you do a mammogram to sort it out. So screening is never combined with an ultrasound in the first instance. It's mammography alone. You look at a mammogram, and then if necessary, recall the patient for ultrasound. Here, recalling is not practical, so sometimes we do it then and there. Whereas a diagnostic mammogram is always combined with the ultrasound, so this confusion exists, and I don't think even radiologists and surgeons understand this much in our in the wide across the length and breadth in our country. This also should be remembered that in many places these MHC master health checkup reports are not seen by experts in that area. So it is somebody who, part-time doctors or floating doctors or the junior most person sitting there who does the screening or does the reporting. So the reporting is very defensive. So I've seen reports where it say BIRADS 1-2, BIRADS 2/3, BIRADS 3/4, and all sorts of numbers and very defensive reporting, because obviously they're not confident, and so therefore it results in too many investigations, a lot of stress, unnecessary surgery, and the worst outcome is missing cancers. So if you do a test and if you say something, even if it's a false positive finding, the woman is at least likely to go and seek help to sort it out. So that way there is some continuity in that effort, and then they resolve it. But if you say it is normal, and then the lady is likely to go and put it aside and ignore it. And even if she develops a symptom, she's got that false sense of security. Oh, I just had a mammogram 3 months back, this is probably nothing, and she's going to sit on it, and that is worse, missing a cancer. So all these are major issues. And then should also be remembered, most of these images are not archived in packs in many centers, and because packs cost money, and storage is a big storing and retrieving is actually a big challenge. And most centers actually give the reports, and the onus is on the patient to keep the reports and films, and most of these degrade with time, and it's not available for comparison, it's lost for comparison. And then there's no follow-up. It's standalone centers and hospitals doing these procedures. There's no audit or follow-up of what happens to that patient, so there's no learning. So therefore, in 10 years down the line, if I give another talk like that, the issues will remain the same. 20 years, the issues will remain the same. It's unfortunate, but that's the truth. So all of these are major issues. So what is the solution? What should we do in our country? So Tata Memorial Hospital came up with a study which reported a few years back. The results indicate that clinical breast examination conducted every 2 years, because this was a cluster randomized trial comparing clinical breast examination to no examination. And then they showed 15% reduction. It was non-significant though in mortality overall. But in women aged 50, the reduction was nearly 30% and was significant. So there was no significant reduction in mortality seen in women younger than 50. So this also kind of mirrors what we see with mammographic screening trial results that come from the West. So maybe in our country, as a national guideline, we should rely more on clinical breast examination and train our ASHA workers and VHNs to do clinical breast examination. And it's probably the recommendation for most low and middle income countries. So self breast examination, clinical breast examination, probably starting from the age of 40 every 2 years. And also offer opportunistic, you cannot deny a mammographic screening for women who wants to screen. So offer opportunistic mammographic screening, and some sort of, so now there are organizations like for breast, we have our breast collaborative group. There is this Association of Breast Surgeons of India. There is a BISI, Breast Imaging Society of India. So we should, they're doing a lot of good work, and we should come up with more training programs and more guidelines and some form of audit. And we should also advocate high-risk screening. So, BRCA mutated breast cancers are real. It's not something only that is seen in Western countries. So we do have a need for high-risk screening. So another paradox that we see is abuse of PET and breast MR. And breast MR is also a test that people request without understanding what the test is all about, the indications, and what are the pros and cons of doing it, and the technology itself. So I have seen breast MRs with body coil, without breast coil, and I have seen breast MRs without a clear protocol, no sequencing, no kinetic studies. So these things again become a challenge in reporting. And this patient walks in with a breast MR and I say it's still inadequate, I look like a fool in front of the patient, and because they pay for the test but do not get the right information, and it becomes difficult for us also to push for more tests. So these are all the paradoxes that we see in our system. Pathology is another big paradox. There's still this debate of FNAC versus core biopsy, and a decade of ABSI and BC, I don't think we've still settled the debate. So it should be core biopsy. It should be guided core biopsy preferably. And so we do conduct workshops, and anywhere such a workshop is needed, feel free to contact us from the breast collaborative group. A group of us will come and do it to demonstrate, to train people, and we also can take in observers who can come and see how these things are done. So again, in pathology, there is no uniform reporting, and IHC is another big. So IHC, the immunohistochemistry, it's a biology-driven treatment. ER, PR, HER2 is the cornerstone in deciding what patient gets in terms of the sequencing of treatment, the need for chemotherapy, hormone therapy, and all this depends on this doing this test. And if the specimen is not fixed properly, and there are like pre-analytic issues, post-analytic issues, if it's not done properly, then then whatever you do treatment wise, it's not going to be effective. And whereas we have all these challenges on the other spectrum, we do tests like easy breast and liquid biopsies to tell us if there is breast cancer, and all sorts of advancements there. So this is the paradox that we see in our country. So as far as just coming down to management, surgical resection was the first effective treatment, and is probably still the most effective treatment for breast cancer for a curative intent. And it evolved from highly morbid procedures to cosmetically acceptable safe surgeries. So the ever-growing comprehension of breast cancer biology led to substantial advances in molecular diagnosis and targeted therapies, which actually improved outcomes, and you see very good survival outcomes with reasonably good quality of life. So Hiram Cody, in his presidential address, said this, and it's often quoted now: biology is the king and selection is the queen. How we select sequence is the queen. For what treatment, that is the queen. The technical procedures, like what we surgeons do, I don't know whether Geeta will agree with this, are like the prince and princesses, and occasionally we try to usurp the throne, but they almost always fail. Biology continues to rule. And to look at the chronology of how the major cornerstone developments in breast cancer management, we all know William Halsted in the beginning of the 20th century. For about 70 to 100 years, Halstedian radical mastectomy, or the ultra radical, supra radical, whatever radical, continued to rule the roost. People were cured of breast cancer, but had a very, very poor quality of life. And this was all based on the premise that breast cancer was only a local disease, and removing it as extensively as possible will cure. And then the understanding changed, and actually, interestingly, the World War II and the use of mustard gas in World War II actually developed the understanding of use of alkylating agents and chemotherapeutic agents, and with that understanding, the NSABP trial started somewhere in the 70s with chemotherapy. So Bernard Fisher was a key person involved in the NSABP trials. And one of the earliest trials were actually looking at local treatment, and then without radiotherapy, then auxiliary clearance, with and without auxiliary clearance. And so some of them are still gold standard to refer to, the BO4 and the BO6 trials. And then the question of, the de-escalation started happening even as early as the 1970s. Umberto Vernozzi from the European Institute, it was an European Institute of Oncology, then it was Milan Institute, and then he went on to form this EIO, European Institute of Oncology, passed away recently, 4 or 5 years back. He actually promoted this quadrantectomy, very, very disfiguring operation, with some semblance of breast left behind, and proved with equivalence to mastectomy. So some of the earliest trials were from Milan, showing equivalence of breast conservation to mastectomy. And then in the 1990s, More research led to the identification of what used to be called as CERB2, which is now known as HER2, the epidermal growth factor receptor 2, HER2. And this man, Dennis Lehman, actually was was the person involved in identifying this molecule called trastuzumab, which changed the outlook of breast cancer to the extent that now in the staging of breast cancer, if you're HER2 positive, it actually downstages, even though the tumor size or the node might be a slightly higher stage. With being HER2 positive, with available anti-HER2 therapy, it is downstage the cancer. So anti-HER2 therapy is the most effective targeted therapy available for breast cancer now. And then there's also a lot of, by that time, Watson and Crick had this DNA model, and then a lot of work on the DNA. And then Mary Claire King, she was the one who came up with this BRCA1. She doesn't like it being called BRCA, by the way. It should be BRCA1. So BRCA1, and then subsequently BRCA2. So of the hereditary breast ovarian cancers, 80% of them are accounted by mutation in the BRCA1 and 2 genes. And then some other genes like PALB2, CHEK, P10, P53 all came later. So these account for a very small proportion. But earlier we used to do Sanger sequencing, which could take months to get results and very, very expensive. Now there is this NGS platform where things are done over a period of 10 days or 2 weeks, and you look at a wide range of mutations. And there is a problem of the variation of unknown significance. But largely there is some more clarity with these NGS platforms. And then surgically, so the surgical advances kind of, had a break for about 30-40 years. Nothing much happened there. We're only debating about, various types of mastectomy and various types of breast conservation. So when I started training, I remember in the late 80s and early 90s, we were removing big chunks of tumor and leaving behind cavities to fill up with seroma, and then they'll have radiotherapy. It'll all look hunky-dory in the beginning, and then 5 years down the line, the breast will be pulled in, east, west, north, south, all directions, with all the fibrosis that happens with radiotherapy, and a very poor quality of life. Breast doesn't look good, and there's no point in leaving behind a breast that looks deformed. So and then a whole branch of oncoplastic breast surgery happened in the new millennium. And one other major issue with a lot of surgical extirpation of axilla, surgical clearance of axilla, was lymphedema. So Armando Gugliano in the early part of this millennium came up with this sentinel biopsy, which is now the standard of care for clinically and radiologically node negative breast cancer. So therefore we avoid unnecessary axillary clearance for node negative people and avoid the risk of lymphedema. So that's in a nutshell about what happened over the last couple of last 100 years. So the problem with breast surgery in our country is everybody wants to have a pie of it, from general surgeons to gynecologists to breast surgeons to surgical oncologists, plastic surgeons, except possibly the orthopedic surgeons. Everybody wants to do breast surgery, or because it's the thing is, it's seen as okay, it is a surface organ, and it's only a breast after all, and it's like taking out a lipoma or a soft tissue lesion. What's the big deal about it? I've heard people say that, but it is I would differ with that. It is not that simple. And currently de-escalation is the theme. We want to do less and less, and one day we run the risk of surgeons not being required at all for managing breast cancer. But right now we still have a role, and more and more we try to conserve the breast. We try to conserve the breast and leave behind a better looking breast, and then conserve axilla too, to avoid lymphedema. So quality of life and survivorship are major issues that that dictate treatment right now. And so obviously there is a huge advantage of breast conservation over mastectomy, the psychological benefit of maintaining breast and body image. So when you do a breast conservation, should be remembered that it's almost always combined with radiotherapy, except with some exceptions. The equivalence to mastectomy was established in the 80s and 90s, as I mentioned earlier. More recent studies and audits now, we've had a couple from Netherlands, have established superiority of breast conservation over mastectomy, particularly in early breast cancer. Confounding factor here could be radiotherapy, because breast conservation people almost always have radiotherapy, whereas mastectomy for early breast cancer may not need radiotherapy, and maybe this is one of the confounding factors. The other could be quality of life, that really mind matters, and the feel good factor after any treatment matters for survival too. So the long-term results, obviously the earlier breast conservation led to very poor quality, cosmetic outcomes, but with incorporation of plastic techniques, the cosmetic outcomes and therefore quality of life has improved. So the understanding of blood supply. So we started doing more and more of MRs. And when you do MR and give contrast, you see a lot of blood vessels crossing the breast. And we started understanding the blood supply of the breast and started designing pedicles based on this blood supply. And with evolving, combined with plastic surgeons, they do all the reduction techniques, volume displacement, volume replacement, all these options. Resulted in an emerging specialty. So we took a bit of work from plastic surgeons and a bit of what we know from oncology perspective, combined it together, and we have new breed of surgeons called oncoplastic breast surgeons. So this involves integration of plastic surgery techniques, like I mentioned earlier, so we can excise more, achieve better cancer resection and better cosmetic outcomes. So up to about 10% of loss of breast volume may not affect cosmesis, and you can just put it back together. But if in a larger breast, about 25% can be removed without affecting the outcomes. But if anything more is removed, then the surgery involves some bit of glandular reshaping and skin excisions. So there are a lot of advantages with oncoplastic surgery, particularly in very large breasts, in very, D cup, double D, E cup, F cup breasts. You do a mastectomy, she's going to be lopsided forever in her life. If you just do a lumpectomy there because it is feasible, then radiating that breast will be a nightmare. You cannot achieve dose homogeneity, and she'll have a lot of reactions. So that way, doing a therapeutic reduction, actually it is like a cosmetic reduction for that patient. She has a better looking breast eventually, and it also tolerates radiotherapy better. So it has its there are some advantages. So the challenges that we face in surgery, particularly with women, so we go into a panic mode as soon as a possibility of breast cancer or a diagnosis of breast cancer is made, and people hurry into making decisions, go and have an unwarranted excision biopsy, or jump into something without doing proper research or understanding about what is best for that given situation. And again, a lot of situations where women do not decide. It's the extended. I see that change now. The trend is changing. I see more and more women being more empowered. But even a lot of decisions are made by their general practitioners who refer, the gynecologists who refer, the extended family, including mother-in-law, father-in-law, uncle, auntie, friend, husband, mother, father, sister. Women do not get to children, particularly, lot of parents now, particularly in Chennai, in South Chennai, they're all alone here because children live in other countries and they are able to come only for a few weeks for all these procedures and all that. It is challenging for them too, but so things I find get hurried up, and do procedures before you understand what's happening, and all these are major challenges. And sometimes we end up doing mastectomy just to without proper understanding of what that woman wants and what is suitable for her social and personal quality of life. And reconstruction, whole breast reconstruction is very slow to take off. We're now doing a reasonable amount of immediate breast reconstruction. I would it's still below 10%, but there is some awareness about it. It has to reach a critical mass for it to actually be talked about and done more often. Implants never took off properly, at least in Chennai. Every other implant is all right. Your teeth is all right, heart valves are all right, hip replacements are all right, knee replacements are all right. But when it comes to breast implant, people start worrying about this implant induced the odd whatever lymphoma. I think that gave a lot of bad publicity, and so that is a big deterrent. And people, I think people go for cosmetic augmentation, but when it comes to reconstructing the breast with implant, there is still a big hurdle that we have to cross. Cost is also a major concern. So again, coming back to who's the king, biology is the king. As a surgeon, I definitely admit that. And in all that confusion of all this various research and pathways and molecules and this target and that target, HER2 was the only bright light that came up in the 90s. And some of the patients who were treated with anti-HER2 trastuzumab in the metastatic breast cancer trial that Dennis Lehman did in the late 90s, some of the patients that were treated in the trial are still alive. So it shows the efficacy of anti-HER2 treatment. And so in IHC, like I said, is crucial in planning treatment. So when we do a core biopsy, IHC is done on that core biopsy sample. Unfortunately, I recently went for a surgical update meeting for postgraduates down south, and I heard one of the professor of surgery in one of the panel discussion or the case presentation by the PGs mentioned about IHC being done in a blood sample. So that is a level of awareness among surgeons in the teaching fraternity. And what will the students learn? Sometimes it's very, very frightening. So IHC is done on the core biopsy sample. Sometimes we repeat it on the tumor sample also, but the best sample to do is the core biopsy, because as soon as the core is taken out, it's put in buffered formalin, it's fixed well, and it's studied immediately, so that there is no pre-analytic issue when you do it on a core that is done well, and the results are most accurate. And this is important to, so if it is ER/PR positive and HER2 negative, you plan it, you operate upfront, particularly in stage 1 and 2 breast cancers. If it is HER2 positive, the tumor size is more than 2 centimeters, less than 60 years of age, node positive HER2 positive patients should not undergo surgery upfront. They should have neoadjuvant systemic therapy that includes chemotherapy and targeted therapy. Should be periodically examined every 2 cycles preferably, and we should also insert a clip up front or at least midway during the chemotherapy, because with the targeted therapy that is available. So now we have dual targeted therapy, trastuzumab and pertuzumab. So this combination, a good 60 to 70% of tumors disappear with this therapy. And then you go and try and to So right now, we don't have the means to prove that the tumor has disappeared. So the radiological means are still inaccurate. So we still end up doing a clipectomy. So we go and localize the clip and remove the clip and surrounding area and subject it to pathology. And that shows no tumor, then we call it a PCR, pathological complete response. And the node. So we also assess the node at that point. So the response in the primary breast and the node is an important decision-making assessment for further de-escalation or escalation of treatment. So if there is a residual cancer burden, then we would change our targeted therapy strategy. We would use TDM1. But if there is no complete response, no residual tumor both in the nodes and in the breast, then we would continue with only trastuzumab for the remaining, a total of 17 cycles for a whole year. So we would do that. So this is very important. And so, and if you operate upfront, then there is no scope to escalate the treatment if there is no response to the initial anti-HER2 treatment. So therefore, there is an advantage in administering anti-HER2 treatment and chemotherapy upfront. And also, there is scope to conserve the breast more. So when it responds, then you end up removing less volume, and therefore better outcomes, better possibility of increasing the rates of conservation, and better outcomes in terms of cosmesis. So the same with triple negative breast cancer. So if you have a patient with triple, what we mean by triple negative is ER, estrogen receptor negative, PR, progesterone receptor negative, and HER2 negative. All three are negative. That means this tumor is not driven by HER2, this tumor is not driven by estrogen and progesterone, and it is independent of these three. And therefore, and these treatments are aggressive and chemotherapy. And right now we have some immunos for the triple negative breast cancer too. Pembro has been approved and it's used in the neoadjuvant setting. So again, a triple negative patient that is more than 2 centimeters, node positive triple negative cancers should undergo neoadjuvant chemotherapy with or without Pembro. That is a targeted therapy, especially in the young patients. And triple negative patients are more likely to be associated with mutations, hereditary inherited mutations. So the guideline is anybody with triple negative now gets tested for mutation. So the testing for mutation is useful for not only managing the risk for contralateral breast cancer in that woman, and the possibility of ovarian cancer risk for her, and then cascade testing for the rest of the family as to whether they have inherited the same mutation or not. So therefore, that is useful. And here again, residual cancer burden. So after chemotherapy, we operate, and the triple negative tumors respond very well to chemotherapy, and a good 60% of tumor disappears. And then we so here again we leave a clip here in the tumor, within the tumor. So even if the tumor disappears, we use the clip as indicates the footprint of the tumor, and we localize the clip, remove the breast tissue, what I call clipectomy, because there's nothing there to remove except the clip. So you localize, remove the area where the tumor was, send it for pathology, and the nodes also. And if there is complete pathological response, if there is no tumor seen, then she does not need any further treatment. And now, if we've done a mastectomy, then they may not even need radiotherapy. If you've done a breast conservation, they obviously need radiotherapy. But if there is residual tumor burden, then we currently we use additional chemotherapeutic agents orally administered called capecitabine. And so this advantage will be lost if we operate upfront. Surgeons have this itch to operate every breast cancer that we see immediately. As soon as you see a lump, either remove it, or if you diagnose a breast cancer, do a mastectomy. So, without understanding the biology. So this is something that we should desist. And then in patients where there is mutation, known mutation, then olaparib is also used in the adjuvant treatment protocol. So that is where testing becomes important. In hormone-dependent breast cancer, so here in stage 1 and 2 breast cancers, we could be actually over-treating with chemotherapy. So therefore, there are recurrence scores available to assess the risk of recurrence, future recurrence. And therefore, if the score is low, then you actually avoid chemotherapy for these patients. And if the score is high, you actually select them for chemotherapy. So earlier we used to use the NPI, Nottingham Prognostic Index, and all the pathology reporting based on tumor size, nodal status, grade, and all that to determine the need for chemotherapy in hormone receptor positive breast cancer. But there is a room for error. A good 30% of them actually could be getting overtreated, and a 30% of patients who actually need chemotherapy could actually may not get based on these prognostic factors alone. So to stratify it better, to give a so these recurrence scores are done. So the most popular one is Oncotype DX, which is used in the US and most other countries too. And Europe, of course, they have to be different. So they came up with Mama Print, and some other recurrence scores are also available. So indigenously developed CAN assist is available in our country. This is actually based on IHC. So it is priced lower, and it has been validated, and some actually prefer for using CAN assist in our country. So in premenopausal women, for ER positive breast cancers, tamoxifen is used. So where tamoxifen cannot be used, so if there is a DVT risk, or there is some side effects associated with one of the adverse effects associated with tamoxifen is endometrial cancer, and you keep following up, they keep getting all these endometrial thickening and keep repeated DNCs and polyps, hysteroscopy and polyp removal, and all these keep surfacing up over the period of follow-up, and sometimes we end up actually stopping tamoxifen. And if they continue to have a high level of estrogen, then we use ovarian suppression and aromatase inhibitors. In postmenopausal women, aromatase inhibitors, letrozole, anastrozole, or exemestane are used. There's not much difference between the three. So whatever one is comfortable with or familiar with, and cost could be a concern also to select an aromatase inhibitor. So this is accompanied with a 6-monthly bisphosphonates, and the preferred agent is intravenous zoledronic acid. And sometimes this is a challenge if we do in some. So there is a double benefit here with bisphosphonates. One, that it prevents bone-related recurrences. There is a 1% survival benefit with using bisphosphonates, bone-related metastatic events, and also prevents osteoporosis and osteoporosis-induced fractures in women who take letrozole. So postmenopausal women, elderly who are already at risk for osteoporosis, they take letrozole. It completely nullifies all the estrogen, zero estrogen there. So therefore, they are more at risk of developing osteoporosis, and that is kind of negated by using IV bisphosphonates. So the duration of therapy, we initially started with 1 year, then it moved on to 2, then it's 5. Now we debate between 5, 7, and 10. And so it's decided, duration of this endocrine therapy is decided by risk factors. So currently there is this BCI, breast cancer index. It's also like a recurrence score available that with which we choose. I mean, it's not still widely used here. In the US it's used, but here we go by grade and node positivity and the size of the tumor to decide whether to continue beyond 5 years or stop at 5 years. So currently we also add one more agents, the CDK4 inhibitors like palbo, ribociclib, and abemaciclib is now approved for adjuvant therapy in patients with node positive, hormone receptor positive women. So this has been shown to increase survival outcomes. So there's a lot happening in the medical oncology side. Obviously, cost is a concern. Public healthcare in our country is free, but time to treatment and quality is very variable. And private healthcare is not all glory. It's still a lottery and can be very expensive too. Generics have made chemo and targeted therapy cheaper. So that is one big advantage. And, tamoxifen, which is kind of been used for breast cancer, and it still continues to be used, like I said, in premenopausal breast cancer for well over 30 years now, and it just costs a rupee. So with the lot of pricing policies, actually cost of medicines have come down significantly and easily available too. And so radiotherapy developments have also happened hand in hand. So when I remember in the 80s, it used to be the cobalt machines, and you do a breast conservation. Not that we did great breast conservation those days anyway, but whatever we did, the breast used to look like one fried something dark patch there. So from that we've moved on to conformal intensity modulated radiotherapy, and with the deep inspiratory breath hold technique, we avoid a lot of cardiac related morbidities, especially on the left sided breast cancers. And hypofractionation has become the standard now, and finish all the fractionation within 3 weeks, and with very good outcomes. And around COVID, we had this study from UK, Dr. Whalen, I think, fast forward trial, which fractionated within 5 days. And so this does not include axilla. So fast forward is only for breast. And so this completes the radiotherapy within 5 days. And for very early breast lesions, for selected patients, this could be a very good option. And for in our country, actually, it solves a lot of problems. Compliance becomes better, conservation rates are higher, cost could be less because the machine time is less, the number of fractions are less, so the cost could come down. And the machine time is available for many more patients. The problem in our country right now is availability of radiotherapy machines. So therefore, all this could be an advantage in the long run. And the results are equivalent in terms of complications, side effects, and survival outcomes. So
you need to wind up, Selvi. You're allocated only 40 minutes. It's 60 minutes now.
Sorry. Okay. So this is one study that we published. It was in 2020 Nature Scientific Reports, 3 people data. That's one from my set of data, Dr. Doval's data, and Dr. Ramesh Nimagada. And these DFS and OS 88 versus 94, similar to the rest of the world. So we are doing something right. And just to show that in a corporate kind of practice, in private practice, stage 2 breast cancers account for about 66%. And the vast majority of cancers still are hormone receptor. So it's 55% when compared to 60 and 70 in the West are hormone receptor positive. And in our study, we found that in over 3,000 patients that we looked at, tumors under 3 centimeters, the outcomes are still good. So that goes for saying that clinical breast examination could still be a better outcome. And just a quick word about, because I'm kind of very interested in all this preventive work right now, So these are, I'm sure these things have been addressed. Bose has done a talk on marvelous medicine, and all this was addressed. So this actually sums it all. So hormone positive postmenopausal breast cancer is largely lifestyle related, and avoiding lifestyle related issues and following all these decades here could actually prevent that 60% of breast cancer that we see in our country today. Thank you.
Over to you, Dr. Geeta.
Thank you, Selvi. That was very, very comprehensive. I really don't need to add much, just a few thoughts, because these are practical things that we come across so many times, and I'm sure Selvi and I deal with it all the time. So one thing is, as young surgeons, I think most of you should understand the importance of documentation. It is never going to be old-fashioned. I think we're doing a great service, not just to ourselves, but to the patient and to our radiation oncologist, whoever comes after us. It is always good to document your clinical findings, have pictures drawn so that, it adds to the kind of, the finesse with which they treat patients. And just as Selvi said, one has to image before intervention. I don't know why there is this huge need to push in a needle, and it is usually a fine needle which does not give you information, and a lot of times it can be a false sense of security if it just comes back as negative. And so it has to be always imaging before intervention. And the sad part is only today I saw a patient who had got an MRI of the breast done as the first investigation, which is really a sad commentary on, and this is not a general surgeon, this is a surgical oncologist, an MCH trained person who's actually doing an MRI as the first investigation. That should not be. So there is a certain protocol that is to be followed, and we must understand that every imaging gives you a different set of information, and each piece of information is important. So it is obviously mammogram, ultrasound, and MRI is to be reserved as a problem-solving tool and to be used in specific situations, which Dr. Selvi has already enumerated. So with, people condemn breast self-examination. The West condemns it because they have a screening protocol in place, and so they don't think much of breast self-examination. But I think for our country, breast self-examination makes a lot of sense. And clinical breast examination has been shown by the Tata Memorial that it does make a large impact in terms of mortality, especially in women over the age of 50. So breast self-examination, I would say, young women should start doing it as early as 20 years, because familiarity with your breast is what is going to help us catch disease early. Like Selvi also mentioned about the pathologist role. Unfortunately, what has happened is we have general pathologists. We don't have that brigade of pathologists that we're looking at. So if you look at an MD Anderson, they have got 20 breast pathologists. And here we have a pathologist who's reporting on everything, all and sundry, whether it is gallbladders or appendix, and then there is a breast specimen to report. So obviously there's a lot of pressure on our pathologists, and their task is not easy. And I'm sure we all realize, and even the pathologist understands, that it is their diktat that is going to actually influence the kind of treatment that is going to happen, and can influence outcomes also in a large way. And the other thing that I want to also emphasize on, we are treating women. Let us be more sensitive about women's needs. Let us not assume that it is okay to do away with her breast. It does not matter. Well, that's not true. If she is amenable to breast conservation, we should be able to impress upon her the safety of a breast conservation surgery. And we now know that breast cancer conservation surgery is actually associated with better overall outcomes as compared to mastectomy in suitable cases. And let us not be very trigger happy and say that it does not matter if you remove the breast, what's the big deal, let's get rid of the breast and let's get rid of the ovaries, which I think is a very trigger happy method of dealing with young women, be very cognizant that, removing ovaries young age is not a great thing. And when I hear young women with, okay, they are mutation carriers, even if they are mutation carriers, let them hold on to their ovaries till the age of 35 in BRCA1 mutations, and let us not be in a hurry to get rid of their ovaries, because they are living long. Because now with improved treatments, these women are living long, and we should be very, very, aware of the fact that they could be living on to be 80 years old, but at the time they're 50, they start fracturing because we have done away with their ovaries when they were 25 or 26. And like Selvi said, trastuzumab, I think trastuzumab is possibly one of the biggest revolutions that happened in breast cancer medicine. And the results that we're seeing with targeted treatment is huge. And with the cost having reduced, it is accessible to more people. And we are seeing exceptional results with trastuzumab, and now the pertuzumab has been thrown in. But I still want to put the crown on trastuzumab as that one drug which really changed a lot for those women whom we possibly never realized were HER2 positive and we lost. But now with a lot of patients who are HER2 positive undergoing targeted treatment, we're able to see very, very good outcomes in them. So, it may seem a little strange that, the surgeons being relegated to second spot, considering that, about 10 years ago, surgery was the first thing that we offered all patients. And now with this plethora of drugs, I think sometimes the medical oncologists also struggle to figure out which molecule to treat the patient with. So obviously we do surgery after the targeted treatment or the immuno and the chemo and all of that. But I think, we are magnanimous in the sense that we do embrace science and keep with the times. And anecdotes don't make science. So that is something one must remember. And we always are in this habit, that patient, she had liver meds, lung meds, brain meds, and she's still alive and she's 5 years down the line. So those are anecdotal. So let us be real and continue to keep pace with what science has to offer. And I think it's a law that it offers. And at the same time, let us always believe that our patients are going to live long. So if there is a young patient, let us discuss fertility options. Let us not think, it does not matter. What if she doesn't, we don't know whether she's going to live. She is going to live. Let her not live a life of regret. Let us discuss all the options that she needs to know, whether it is fertility, whether it is genetics. All of those options have to be discussed, because we have to give them the power of choice and not believe that she doesn't need to know. Like Selvi mentioned, radiation has also made huge strides. It is very, very safe now. And we've stopped seeing those charcoal pieces on the chest, because I remember seeing a patient who had a hard rock on her chest, and I realized that she had been irradiated with cobalt, and things have changed a lot since, and it is an amazing add to our armamentarium. And that is what I have to say. And I think Selvi has covered it beautifully from end to end. And I'm sure you would have benefited from that lecture. Thank you. So if there are any questions, it would be great. There was one question that I saw, Selvi, which said, what is the importance of PD-1 or possibly PDL-1 in breast cancer?
Yes, I think you leave it to the medical oncologist to decide how they want to go with immunos and yeah.
Yes, and one must remember that all these immunos and the targeted and all of that is accessible to less than 3% of our population. So it is all nice and good to be gung-ho about all these advancements, but we have to know where it ends and where it starts and where it ends. And we should always remember that the patient should never feel bad about not being able to afford a certain treatment. So we have to talk to them in a manner which does not let them feel, if I were to do the immuno, I would survive. And if you were to not do the immuno, I would not survive. I think, our conversation with the patients around these expensive molecules has to be very, very cautious and guarded. And let us help them do what is best possible.
So shall I just read out another question? Is if
Yes.
there's a strong family history of CA breast, what shall we do for other female family members?
So if there is if the index there is a already diagnosed patient in the family, then that patient should be tested for germline mutation, genetic mutation. It's a blood sample. So before testing, we do a then pre-test counseling. So this involves drawing up a 3-generation pedigree chart, understanding the entire family, whatever information that is available, and then we discuss the test and the test outcomes. So if the test is positive, then what are the strategies that are going to that are likely to be followed? If the test is negative, then what do we do? If the test is indeterminate, like you have some variation but it's of unknown significance, then what strategy we use? All this is discussed upfront, and then we send a sample, and that takes about 2 to 3 weeks. And after that, then if it's positive, then we discuss again the risk reduction strategy or the surveillance strategy, whatever that we've discussed before, and we reiterate and discuss it again, and then follow appropriately. So, and then also cascade testing. So women over the age of 25 are offered cascade testing, which is for them testing. So if you've already tested and you've identified a certain segment where there is this known mutation, then they do not have to go to the entire NGS panel, and you could just select and do that part of the study. It could be cost effective. It could actually be half the cost or probably 1/3 the cost, and the rest of the family can be tested. But remember, before testing, they have to understand the implication of testing. So otherwise it's like sitting on a time bomb. No, you know that you're positive, but you're not ready to deal with it. So therefore this pre-test counseling is very, very important before we do genetic testing.
Absolutely. So there is another question, which is intrauterine device, producing progesterone. Is it safe in triple negative breast cancers?
It's local progesterone, and triple negative, as we know, is not hormone sensitive. Therefore, yes, they can go ahead. We even recommend, vaginal estrogen, because they get into chemo-induced amenorrhea, chemo-induced menopause, and then they struggle with menopausal issues. I don't hesitate to use local estrogens for triple negative patients.
Right.
Anjali Dawle asks whether same receptor study is done for male CA breast also. And
yes,
what is the
absolutely. Male is no different from female breast cancer, same way, no difference at all. In fact, if anything, for all male breast cancers, I would definitely, whether they are ER positive or triple negative, they all undergo genetic testing, because most male breast cancers are directly related to BRCA2 mutation. And not only them, the rest of the family, women in their family, men in their family should be screened for, counsel tested for both breast and prostate.
And most male breast cancers would be ER/PR positive.
Yeah.
So, Dr. Sridhar, plastic surgeon, is asking, is there any role at all for radical mastectomy? And is there any role for lymph node transfer in lymphedema?
So they are doing this lymphovenous shunts now. I think it'll die its own death in future. But upfront, when they do the modified radical mastectomy itself, there are a lot of surgeons who are now doing the lymphovenous shunts. They do randomly 3-4 shunts at the time of modified radical mastectomy itself, and they claim that it will reduce the lymphedema risk. But in established lymphedema, the lymphatic channels are likely to be large enough to do some lymphovenous shunts. And sometimes when you go and release the fibrosis around in the axilla, so we've noticed this, somebody who has, I recently they did a delayed reconstruction. This lady had a lymphedema, or moderate lymphedema, and she had a delayed reconstruction done. And so the DF anastomosis was done in the axilla, and at that point they open up that area and fibrosis. So that itself actually relieved the lymphedema. So in established lymphedema, doing lymphovenous anastomosis actually probably could be therapeutic, but I'm not sure. What do you think, Geeta, about upfront lymphovenous shunts during mastectomy, modified radical mastectomy?
I'm not doing it. I also think it's an overkill because we must realize that whichever way you look at it, the incidence of lymphedema, of intractable lymphedema, is actually even lesser. So it's about 20-25% in those who undergo an agri dissection. Of those, about 10% will land up with intractable lymphedema. And to be offering it prophylactically is a bit much. Yeah, a bit much because, and the pressure difference is not there. So the pressure difference will build up as, like you said, there is fibrosis and there is, the lymphatic channels swelling up, and then you're trying to push it into a vein which is less hydrostatic pressure as compared to the lymphatic channel. So when you're doing normal channel to vein, I sometimes think that possibly the vein has got more pressure and pushes back the lymph, and in some ways possible. So I don't do prophylactic.
I just
LVs.
asked this question mainly because we
sir.
start seeing cases where we do the lymphangiogram and then we find the pressure is low. As a matter of fact, as she put it rightly, it is the pressure is more high on the venous side rather than on the lymphatic side. So somehow this intractable we start seeing nowadays. And I just want to add an information that we do a microvascular submental node transfer. So we do a submental node along with the artery vein and then do a microvascular anastomosis in the arm, and we find the lymphatics grow into the node and then it starts draining much better. This is one of the recent things which is happening in the reconstructive surgery domain, which is not being illustrated or it has not been known to many. So in cases where there are intractable things, where lymphovenous shunt is also not possible, then the choice of doing a lymphatic node transfer along with arterial and venous anastomosis in the wrist region or elbow region. So dependent region, we feel that it tracks down into that and more lymphatics grow into the lymph node, which is already viable because of the arteriovenous anastomosis. This just I wanted to add this information. In cases roughly about 10%, we do see few cases and our results have been quite encouraging.
Okay, sir.
So there is the concept of groin lymph node transfer.
Yeah.
So there is the concept of groin lymph
nodes are the labia and the thigh edema becomes more than when you transfer your submental node. You have to be really choosy when you are choosing the groin nodes, whether it is the vertical or a horizontal chain you are choosing. And you have to be really careful in not taking up that which produces the edema in the groin or thigh region or the external genital region. That is something which is required when you are choosing a groin. But if you can take the submental, if it is really working, we find it very easy. And comparatively, the facial artery size is also quite large for us to anastomose it there to any one of the veins or the arteries. So this nowadays, it is just for an added information for people that it is possible. That's it.
Thank you, sir.
I think Rekha had a comment and a question. How about using the biopsy scar as a marker for WLE post NACT? Pros and cons and personal experience of the same.
So where a clip is not available and wasn't placed, then the core biopsy scar can be used. But if again, the biopsy scar sighting is variable. If you do an ultrasound guided biopsy, you can place the scar anywhere, and depending on how you place the probe and do it. And if you do a clinical core without ultrasound, and then there again, like, you could place it as, so it's variable. So it is it's an option, but not ideal.
True. Very true.
So, Rekha, I hope that answers your question. And there are several questions about where you can get the genetic testing done. Should we guide them to some website or something, or what would you suggest?
So there are two CAP accredited labs that MedGenome and Strand.
Could you
So
please type them on the chat box, because somebody has asked for Mumbai and someone else has asked for Chennai.
So these people collect samples from all over
Yes,
the country,
yes. Yeah.
and
So
they
it's
do.
pretty straightforward, actually. So for genetic counseling, they can do an online free counseling and a pre-test counseling, and then they can pick up the sample from anywhere, because they have people all over the country, in fact, picking up samples and sending it to their centralized lab.
So
You said Strand and MedGenome, right?
MedGenome, yeah.
So the Shilpa is asking, if genetic testing done, no need for mammography once a year if you for age more than 40.
So like I said, genetic testing determines the possibility of inheriting a mutation and thereby inheriting a risk of developing breast cancer. That becomes high risk screening and definitely needed. Whereas otherwise, if genetic testing is negative, then mammography currently in our country is opportunistic. So if you strongly feel the choice is given to a woman, and if you strongly feel that, then go and have it at least once in every 2 years. So that is what we recommend. And if somebody is reluctant, I don't push them. So yeah.
And the other thing is, so you are tested for, germline mutation. It is negative, but it does not preclude a chance of a sporadic cancer happening, even if you are tested negative for a genetic mutation. So you should still have mammograms done whenever, meaning, once in 2 or 3 years, 40 to 50, and then possibly every other year, upwards of 50.
So 90% of breast mammo in our hospital is BIRAT 0. Is that the incidence globally? No, it's not. Because see, there are like standard 4 patterns of breast as far as mammographic reporting on. So you have predominantly fatty breast, scattered breast granular densities, heterogeneously dense and very dense. It is a very dense that will be categorized as BIRAT 0. The other 3, they should be able to report and give a score. So the very dense happens in about 10% of women, irrespective of the age. You would think that, as the woman ages, there will be more involution and therefore the breast becomes fatty. But in this extremely dense category or this very dense category, they are likely to be dense even at 80. And that category accounts for about 10 to 15% of all mammograms. So there you would definitely call it 0 and do additional investigation, which definitely will include ultrasound and then more if needed. But otherwise, they should be able to say 1, 2, or 3 based on the mammos.
Yeah. So if anyone has any other questions, please type it in the chat box or put your hand up and we can hear you. Would speak up. Anjali, would you like to say something? Anjali Davle?
Hi, Anjali, are you there?
Yes. Basically, I was unable to mute. Hi, everybody.
We can hear you, Anjali.
Yeah. Good evening, ma'am. Excellent session, and Dr. Selvi has made many of the confusions very, very clear. And rest of the thing, as the sequencing, Dr. Geeta madam has told that clinical examination followed by ultrasound, followed by TrueCut, followed by any other investigation. So the thing is, Dr. Selvi, you can initiate the standard protocol of intervention starting from clinical examination till MRI and till BCT followed by MRM. I think you should come up with standard guidelines by taking into opinion or pan-India study you can start with, I think. An excellent session.
Thank you.
Thank you, Anjali. So
So we have
Yeah.
a group called the collaborative group, which actually group of us, Geeta is the president for this group, and we had a meeting in Delhi early this year. So the group precisely looking at working together, data mainly, focusing on data collection and answering key questions, and thereby coming up with guidelines. So I hope in the future we'll get more.
It should be.
Geeta, do you want to say a few words?
Yes, so this is the whole idea, because there is, so our strength is our numbers, but the unfortunate bit is that we're not able to put those numbers together to make sense. And it is high time that we come up with our own answers. Everybody has tried to do it, and I think that is from where we derive this thought that we should be able to push it a little further. And we are very encouraged and enthused by the response that we've got so far, and we want to carry it forward. And with all your support and your participation, we should be able to do so. And possibly in the coming week, in that group, we are trying to, and Selvi is working on it, and we are trying to put in this simpler Excel sheet, which actually motivates you to put in data, because what you put in is what we will get out. So, so we are working on that, and I think we should be able to do that pan-India.
Monday.
We are almost out of time. Radhakrishna, you have something to say?
He slept off.
I mean, a good lecture, I should say. Just my word. Now, I have certain observations and certain questions. First of all, you see, there's so much breast cancer in our country, and in spite of that, we do not have clear screening guidelines, as you say. Maybe the West also doesn't seem to. And again, there is so much of a improper breast imaging in terms of technique and interpretation. That's pretty sad. And the third thing is that this now the girl surgeons are increasing in number. I hope breast surgeons also increase accordingly. I don't know if that's happening.
It's happening.
That's happening.
The lady surgeons. Yeah. Now the
That's
thing I
happening.
notice is the number of centers available for proper training are very, very few for the volume of breast cancer. I always see Dr. Geeta's center advertising and talking about training, but otherwise, generally, no, you want to respond to that before I go to the next one? Yeah.
I'll just, so unfortunately, so just couple of years back, I applied to the MGR Medical University. So in that website, at that time when I applied, there was this course recognized for breast surgery fellowship. And so with all the details, our 7-year data and whatever we've done in breast and all the facilities that we have, I applied, that big with all the details, and everything was as per the thing required. And I got back a letter 6 months later after a lot of follow-up saying that breast is a part of surgical training in MS and MCH, and there is a surgical endocrinology course which also covers breast, and so therefore there is no need for a additional fellowship course in breast surgery. And I got a letter that from NGR Medical University, from the Vice Chancellor and the Registrar of the University. It was so sad, because in MS, a couple of registrars that I spoke to recently, in all their entire MS career, they saw 2 mastectomies and did not see a wide local excision breast conservation procedure at all. MCH people come out of training without having seen a sentinel lymph node biopsy, and they do probably 3 months of breast. I'm not talking about big regional centers. There are a lot of other centers, and it's only MRM, modified radical mastectomy. Nothing else happens in breast there. And then obviously, but somewhere where we do everything as it should be done, and we say that we want to train people, we pay a university fee to actually get us accredited, and we pay for every candidate that we train, and this is the reply I get. And then what do I do?
So maybe you should try again. Things might have changed, Selvi. If you did it a few years ago, I think you should try again.
That was only, it was only, it was in 22.
Yeah,
Yeah, I
it
think
doesn't change. It doesn't change. And
the
I think
second,
hopefully we'll have a fellowship from the diplomat of from the,
So there
national
is,
board this year, possibly.
I've been talking to them. There is a FNB for breast imaging.
FNB, yeah.
FMB for breast imaging, but there is none for surgery as yet.
I think in the new list, possibly we will see that. And the thing is, it is not just about breast surgery. When you're talking about breast, it has to have the multidisciplinary flavor. So if you talk to a general surgeon or even they do not put everything together. So I, as a surgeon, should know what happens next. So if I don't know what happens next, then I am not doing justice to that patient. So I think it is that multidisciplinary flavor which is missing in most of these areas that you just mentioned.
and in some hospitals I had worked before, gynecologists post breast lumpectomies in their theater. At least I've seen that done, and I also seen breast examination as a part of routine is done by a lady plastic surgeon and gynecologist, which is in the convention. Now again, I also come across a couple of surgeons who say that what is there to learn in breast? If I go observe 1 week, I know everything about, they all think that technique is all that is required in breast cancer, but there is so much thought goes before and after is something which nobody
absolutely
takes it easy. Then the other questions are, is there any difference in the treatment protocol in the government sector versus corporate sector? The outcomes are different. And what percentage of breast cancer patients in India go through this multidisciplinary team?
So before we, so sorry, I forgot what I was going to say. So that definitely there is a difference in public sector versus, so even in regional cancer institutes where things are fairly more standardized than the rest, there is a time to treatment. And one of the regional cancer centers in Chennai, if you go to, by the time you get evaluated and get on the table, it could be close to a month. I mean, it's still not long, it's still okay, but sometimes this subsidy part I don't understand. So you subsidize treatment and make it low cost or so-called low cost. Many of these actually it's not subsidized, they are categorized, and many of them still continue to pay what they pay in corporate sectors but get lesser service. And what happens is that you come make multiple visits. Every time that woman comes, somebody accompanies, a loss of time, loss of work, and the travel, and if they come from outstation stay, all of this actually equals the subsidy that they offer. And it kind of is counterproductive. So these are major issues that we have. And all the regional cancer centers are overcrowded. Unfortunately, they also cannot do much about it. But yes, definitely outcomes are different. Availability of optimal care, like I said, there is a huge disparity in terms of diagnosis, in terms of all the treatment options, follow-up options. There's disparity everywhere, and obviously all of these have to tee in together to get good outcome.
True. And we're seeing a huge surge in the incidence of breast cancer. So I remember about 10 years ago, it was 80,000 per year, new cases. Now we're hitting close to 200,000.
200,000, yeah.
So, we are not raising the infrastructure accordingly. We can keep saying, and the unfortunate bit is the more than 50% of the mortality is happening in our country, which is kind of a very telling thing, So there is a dearth of training. There is a dearth of a complete understanding. And, we may think that, surgery is a small part of the whole thing, There's a lot that goes, like Selvi also said, what goes before and after it. And you cannot just play them down, because only then you have to have it like mathematics in your head. The protocols have to be like mathematics in your head. You cannot be doing one thing today, tomorrow I feel like I think I want to do this and I want to do that. That's not fair to the patient or to anybody else. So, that kind of protocolized management of breast cancer is lacking. And we really sincerely need to put our might together. And I think, that is what we're trying to do. Figure out a method to at least get some basic stuff going, which can improve outcomes for the others also who cannot reach the big corporate hospitals, which is out of access to most, I would think.
One of the issues is for every, sorry to interrupt, for every breast cancer that you diagnose, there are 9 benign conditions or the so-called worried ones who need to be reassured correctly. So there is the difference, in a cancer setup, everything is cancer centered and people ignore that 9 patients who come with breast conditions that are not cancer but have to be differentiated from that of cancer. And that is a big role that we breast surgeons play along with radiologists. So that is missed in regional cancer centers.
Dr. Geeta, Vidya and myself, we started focusing on teaching undergraduates and postgraduates some basics. Actually, I mean, you as a group should focus on these students and, at least visit a couple of medical colleges and do some practical session and make them understand that breast cancer is not that easy to understand and you need to learn more than what you're already learning.
Very true. So when I run this fellowship program, so the students who come in think that, it's going to be an easy fellowship. It's only breast after all. So just like everybody else thinks, but they kind of, can't just figure out what is this. This keeps on going on till 6, 7 every day. And we just don't get to rest because the next day they have to prepare for something else. So there is a pre-op discussion happening in the evenings after your work is over. So they kind of go nuts. So there is a lot. If you want to do it right, I think, there is a lot of time and energy that needs to be invested. And see, I have reached out. I am still trying to reach out to people. See, I'm not saying that I'm the boss of all of them, but I want everybody else to boss it, even if it is a small center. Get your mastectomies right. Get your axillary dissections right. Get your, sentinel node biopsy with methylene blue right. Because I think every woman deserves that much. We can't be botching up things and hoping for good outcomes. That's never going to happen.
Yeah.
So the only thing I want to disagree with you, Radhakrishna, which I'm sure Selvi and Geeta will agree with me, that I don't think it matters which specialty person examines the breast, because most people are not examining the breast. So every opportunity that is offered for a breast examination, if it comes up, let it be gynecologist, let it be anybody, at least let them palpate, then maybe, if some good will come of it.
If I can counter that, Vidya, it's not that others shouldn't, but others shouldn't take off lumps just like that, because many lumps don't require to be taken out, that is the thing, and leave some ugly scar. There are certain principles of surgery. And, frankly, then there are people who are good at it, available, and you should, send to them or take their advice, is what I like to say.
Yeah.
There are a couple more questions. Dr. Rekha has asked a question, Vidya. To see that.
As breast surgeons, you deal with benign breast diseases as much as malignancies.
Yes.
Yes, we do. 9 out of 10 or something else is what you said, right?
Yeah.
Yes. And I think it is important to see the benign, because the benign may actually not be benign. And it is important to see those so-called malignants, because those so-called malignants may not be malignant, so it may be benign. So, that is our job, to differentiate and to, like, just as Selvi said, we have to reassure patients as well. So many times you see granulomatous mastitis and patient comes thinking it is cancer. They come with an FNAC which says it is cancer. So, you have to kind of put your head to it and figure it out. And it is our responsibility. I think as breast surgeons, we do it all the time, figuring out one from the other. And I think the buck stops with us, because we are, in effect, tertiary care givers, and we should be able to handle it in that manner.
Did you want to respond to that, Selvi, also?
Yeah, I mean, so benign is the major chunk of our practice. So the conversion for cancer is something like 10:1 or 9:1. And so if I see 30 patients, only 3 are likely to be cancer. Others are benign conditions.
True.
Right from breast pain to nipple discharge of various sorts to vague lumps, cysts and lumps and duct ectasia and all sorts of things. And I dread March, April, October, November. We get flooded with mammograms that come with all sorts of reports, and then they panic and ask for opinions and all that.
So, if anyone has any questions, please raise your hand now, because we are almost out of time. And if no one has any questions, Geeta, your closing comments, please.
Thank you so much. And I see Dr. Radhakrishnan and now you. I see your undimmed passion. You continue to do these beautiful sessions. So I have had the privilege of participating. And when Vidya was so apologetic about, calling me up late for this event, I said, never mind. This is one event I'm going to go to, irrespective of the short notice, because I know this is a great service that you do. You have a huge fan following across the country. And everybody knows what LGS does and what this program does. And, in fact, there is somebody, I did not mention this program to anybody, but at hospital, they said, oh, you're going to be on this meeting in the evening. I said, yes. I mean, I did not talk about it, but see, everybody knows even without me talking about it. So I think that is the power of the media and medium that you use. And I think you're doing a great job. And I wish you the best of luck to carry on this with the same fervor and passion.
Yeah, we'll probably be reaching out to you when we go to one of the medical colleges in the future.
Certainly.
Near Delhi, definitely. In the north.
Yeah. Selvi, your closing comments.
Irrespective.
Oh, thank you for the opportunity. It was great. I mean, like you said, we should reach out to more people and catch them early, undergraduates. That's the key.
Thank you, everyone.
Vidya, Sharif has got to say something, because I saw him unmute. Yeah. Okay, correct. Yeah, Vidya.
Okay. Yeah. So thank you, everyone.